We start our updates. It's my honor and the privilege to call for Dr. Mohamed Hosney, my mentor and professor of vascular surgery in Qasr Al-Aini. Left subclavian artery revascularization is essential in TVAR cases with zone 0 and 1 landing.
Mr. Chairman, dear colleagues, really it's a pleasure to be here with my colleagues and friends. In order to talk about revascularization of the subclavian artery, you should know that the aortic arch poses special challenges in order to be able to do a safe and durable repair, as it has different and unique anatomic and hemodynamic features. We have different treatment options, either open repair, total endovascular repair, or hybrid approach. In open repair, although it's a major surgery, but in high volume centers, they continue to report that the results of open aortic repair, aortic arch repair is good. The total endovascular repair at the present time, the commercial devices not available, and so we have the hybrid techniques, which is the main line of treatment in these cases. In order to be able to do an endovascular repair, you have to have good landing zones, both proximally and distally. 2 centimeters is sufficient in most of devices available in the market. It should be parallel in configuration and distal to the left subclavian artery and proximal to the celiac trunk, but taking into consideration that excessive coverage might lead to paraplegia. These are the zones, we all know about it, 0, 1, 2, and 3. We are talking about these 3 zones only now. And so we are talking about how to perform a debranching of the arch vessels by endovascular techniques combined with surgery, and this can be done also totally endovascular by chimney techniques. This is how to extend the TVAR device into zone 2 by doing a left subclavian to left carotid artery transposition or carotid subclavian bypass, or we can do it in these cases. We have some complications like frank nerve injury, which occurs in 4% of cases, but there was no association with death, myocardial infarction, or transient ischemic attacks. We can extend the procedure to zone 1 by doing a carotid subclavian, or by doing a chimney to the left carotid and carotid subclavian bypass only. We can extend the procedure to zone 0 by doing a mini sternotomy and a bypass from the ascending aorta to the innominate and the carotid artery with carotid subclavian bypass. Or we can avoid the sternotomy by doing a chimney on the innominate artery and a carotid subclavian bypass. Sometimes we have to extend the procedure by doing, like in type 2, by doing a repair of the ascending aorta and a bypass to the supraaortic vessels, and then continue the procedure with a TVAR. Or in type 3, when we have an aneurysm extending to the descending thoracic aorta, we can do an elephant trunk technique and then continue the procedure with an endovascular technique. Revascularization of the left subclavian artery shows a paradigm shift from revascularization for all cases to no revascularization at all. To now, most of the centers doing routine vascularization, except in some cases like aortic transection, where they can cover the left subclavian artery in these cases. As we know that the left subclavian artery is very important for perfusion of the spinal cord and the brain, and it is dominant in more than 60% of patients. It supplies the spinal cord through the thoracodorsal and mammary artery and its anti-intercostal branches. The coverage of the subclavian artery is associated with many complications like paraplegia, stroke, either affecting the anterior or posterior circulation, even if the image preoperatively shows that the intercept circulation is intact, arm ischemia, type 2 endoleak, which might be up to 7% of cases. And so, but in some cases, it's very important to revascularize the subclavian artery, like in these cases when we have a patent left internal mammary artery to a coronary artery bypass graft, or when we have a termination of the left vertebral artery at the posterior inferior cerebral artery, or other discontinuity of the vertebral basilar circulation. If we have an occluded or diminuted or absent right vertebral artery, and if we have an anomalous origin of the left vertebral artery from the arch, or hypogastric occlusion or severe disease, or if the patient has a periinfrarenal aortic repair. If we have also a functioning arteriovenous fistula in the left arm, or we are planning to cover more than 20 centimeters of the descending thoracic aorta. The current guidelines show that in elective TIVA, in which the left subclavian artery is expected to be covered, preoperative revascularization should be performed, while in urgent cases like in traumatic transection and leaking aneurysms, the approach should be individualized. Waiting for you with the next IMAC, and thank you.
Thank you for very informative lectures.